Welcome to this explainer. Today, we're putting on our detective hats. In the world of rheumatology, clinicians really have to act like medical detectives to uncover hidden damage. And their absolute best magnifying glasses are paraclinical exams. When it comes to a complex, multi-system disease like systemic sclerosis, what you see on the surface is rarely the whole story. The true extent of the condition is hiding well beneath the skin. And to find it, we need specialized diagnostic tools. So today, we're doing a deep dive into how paraclinical exams illuminate the unseen and ultimately save lives. Here is our investigation outline for today. We'll start with the systemic sclerosis puzzle, move to the classification criteria map, look at autoantibodies and predicting organ risk, investigate the GI tract, and finish up with monitoring scleroderma renal crisis. Section 1. The systemic sclerosis puzzle. Okay, let's dive into this. To understand why these paraclinical exams are literally lifesavers, we first need to know exactly what we're up against. Systemic sclerosis, or SSC, is a highly heterogeneous autoimmune disease. Sure, a patient might come in with visible skin thickening, what we typically call scleroderma, but the actual underlying pathology? It's completely microscopic. We're talking about 3 distinct hallmarks here: small vessel vasculopathy, the production of highly specific autoantibodies, and fibroblast dysfunction that leads to an overproduction of extracellular matrix, or fibrosis. Because the real danger is lurking deep inside the internal organs and the microvasculature, just doing a physical exam? Yeah, that just won't cut it. We rely heavily on specific paraclinical exams to visualize the invisible. Section 2, the classification criteria map. So how do we catch a disease that hides so well? Well, for decades, we actually weren't that great at it. We relied on the 1980 American College of Rheumatology criteria, which had a massive blind spot. It required visible, late-stage symptoms like severe skin thickening and lung fibrosis. Basically, if you had early SSC or limited cutaneous disease, where skin thickening is minimal, it missed you entirely. To fix this, a joint committee of the ACR and the European League Against Rheumatism completely revamped the definitions. Their 2013 framework acts as a much better detective tool because it actively leverages early paraclinical exams. Now, what's really interesting is how this additive point system actually works in practice. To be classified with definite systemic sclerosis, a patient needs a score of 9 or more. And crucially, it explicitly scores paraclinical findings. Things like pulmonary arterial hypertension on a right heart catheterization, interstitial lung disease on a high-resolution CT, and SSC-related autoantibodies from blood tests. Those are all heavily weighted. We no longer wait for the skin to harden completely. We actively test the blood and scan the organs. A perfect example of this is the criteria for abnormal nail fold capillaries. A super simple microvascular exam, just using a capillaroscope to check for enlarged capillaries, capillary loss, or tiny pericapillary hemorrhages right at the base of the fingernail, is now a major diagnostic clue. This single, totally non-invasive paraclinical exam gives us a direct, real-time window into the patient's systemic vasculopathy. Section 3. Autoantibodies, predicting organ risk. Once we've classified the disease, the next big mystery is figuring out where it's going to strike next. Think of autoantibodies as unique fingerprints left behind at the scene. Finding one of these specific fingerprints in a paraclinical blood test is huge. It tells the clinician exactly which internal organs are most at risk for future failure. For instance, if a patient tests positive for anti-centromere antibodies, we know we absolutely must monitor them aggressively for pulmonary arterial hypertension. If they have anti-topoisomerase I, also known as Scleroderma, the risk of interstitial lung disease skyrockets. And if we spot anti-RNA polymerase III, that patient is at a significantly higher risk for a life-threatening scleroderma renal crisis. To make sure we don't accidentally miss these crucial fingerprints, laboratories follow a very standardized workflow. It starts with an ANA screening, followed by core ELISA panels. From there, it's all about pattern-guided confirmation, using more complex assays to avoid false positives. Finally, we take those verified antibody profiles and link them directly to specific organ monitoring bundles. These sequential paraclinical tests form an incredibly reliable net to catch disease progression long before the patient ever feels a symptom. Section 4. Investigating the GI tract. Let's shift our investigation to a system that is profoundly affected by systemic sclerosis, but notoriously complex to evaluate. Get this, over 90% of patients will experience gastrointestinal involvement at some point. 90%. It spans from the esophagus all the way down to the intestines. Because of this massive prevalence, routine paraclinical evaluation of the GI tract isn't just an option, it's absolutely vital for maintaining a patient's nutritional status and quality of life. The UK Scleroderma study group actually put together a brilliant consensus pathway for this. Doctors follow a strict algorithm of exams based exactly on how the patient presents. So if someone comes in with severe volume reflux or heartburn that doesn't respond to basic therapy, they get steered toward a specific set of tests. But if they present with dysphagia, difficulty swallowing, the pathway branches immediately to rule out any dangerous obstructions. The actual progression of these functional GI tests is fascinating. First up is usually an upper GI endoscopy, or gastroscopy. This isn't just looking for strictures, it actively checks for a uniquely named complication called gastric antral vascular ectasia. It's often called watermelon stomach because of these bizarre prominent red vessels radiating from the pylorus. Next, a barium swallow might be used to assess the esophagus. Finally, if the patient has severe bloating and malabsorption, the clinician will order gastric emptying studies and specific hydrogen breath tests. These functional paraclinical exams finally reveal the underlying smooth muscle hypomotility and bacterial overgrowth that are causing the patient's distress.
But we have to remember, GI involvement isn't just about pain, it's about malnutrition. Progressive weight loss is a massive red flag. Therefore, combining objective paraclinical tests with validated screening tools is a real game changer. The Malnutrition Universal Screening Tool, or MUST, tracks rapid weight loss, while the GIT 2.0 questionnaire assesses the severity of daily symptoms. Together, they provide a complete, quantifiable picture of the patient's nutritional status, letting the clinician know exactly when they need to step in and intervene.
Section 5. Monitoring Scleroderma renal crisis. Up to this point, we've talked about how paraclinical exams track chronic, slow decline. But now, we need to shift our focus to a high-stakes, acute emergency. Scleroderma renal crisis, or SRC, is absolutely life-threatening. It happens in roughly 10 to 15% of patients with diffuse systemic sclerosis, usually striking within the first few years of their diagnosis. It's characterized by the sudden, acute onset of severe hypertension, paired right up with acute kidney injury. Without incredibly rapid, decisive paraclinical feedback, an SRC leads to irreversible kidney damage or even death in just a matter of days. Let's see how this builds, because the onset is so incredibly fast. The absolute first line of defense is actually a paraclinical exam the patient does themselves, regular home blood pressure monitoring. If a high-risk patient, like say someone with that RNA polymerase III antibody we mentioned earlier, sees their blood pressure suddenly spike by 20 millimeters of mercury over their normal baseline, it is an immediate red alert. This triggers an urgent medical triage to figure out exactly who needs to be rushed to the ICU for immediate IV vasodilators. While the blood pressure cuff sounds the initial alarm, the laboratory is what confirms the crisis. Clinicians will rush an urgent blood panel to hunt for critical paraclinical warning signs. They're checking for a greater than 50% increase in serum creatinine, which proves the kidneys are actively failing. They also look at the blood film for microangiopathic hemolytic anemia, or MAHA. When you look closely, you'll see reduced platelets, massively elevated LDH levels, and literal broken, fragmented red blood cells known as schistocytes. These microscopic clues confirm that the tiny vessels inside the kidneys are completely obliterating themselves. The very second those paraclinical results confirm an SRC, the medical detective has their answer and instantly deploys the cure. The immediate and lifelong administration of ACE inhibitors, drugs like ramipril or captopril, is the gold standard of care. Because we can detect this crisis biochemically as it's happening, doctors can start these drugs right away, bringing the blood pressure down, saving the patient's life, and actually allowing renal function to slowly recover over the next 12 to 18 months. So, as you've seen today, whether it's identifying specific antibodies or spotting broken red blood cells, paraclinical exams are the undeniable key to managing systemic sclerosis. You just have to look beneath the surface. But, diagnostic technology never stands still. Experimental technologies like the AQ multiplex protein array are currently being developed to instantly quantify entire landscapes of autoantibodies all at once. Which leaves us with this final thought. As these incredibly advanced paraclinical tests continue to evolve, how might they further demystify the deepest secrets of autoimmune diseases? Thank you so much for putting on your detective hats and joining me for this explainer. Until next time, keep asking questions and keep looking deeper.